If your doctor told you your blood pressure is a little high for your age and handed you a prescription on your way out, I need you to stop and watch this entire video before you take that first pill. Because what the standard medical guidelines say about blood pressure in older adults and what the research actually shows are two very different things. And the gap between those two things could be costing people their memory, their balance, their kidneys, and in some cases, their lives. Here's what most people believe. Blood pressure should be 120/80, no matter how old you are. If it creeps above that, something is wrong with you, and you need medication to bring it back down. Full stop, end of story. But after more than a decade practicing internal medicine and studying cardiovascular aging, I've seen something that completely contradicts that one-size-fits-all thinking. I've watched patients in their 70s and 80s get aggressively medicated to hit a number on a chart, only to end up dizzy, falling, confused, and hospitalized. Not because their blood pressure was dangerous, but because we pushed it too low. Hi, I'm Dr. John Chester, and what I'm going to share with you today is not fringe science or alternative medicine. It's peer-reviewed research from some of the most respected journals in the world, including the New England Journal of Medicine, the Journal of the American College of Cardiology, and the Lancet. Research that is slowly, very slowly, changing how the best physicians treat older patients, but hasn't yet reached most doctors' offices. In this video, I'm going to walk you through why the blood pressure number that's ideal for a 35-year-old can actually be harmful for a 75-year-old. The specific blood pressure range that major research now suggests is optimal for adults over 65. The hidden danger called overtreatment that sends tens of thousands of older adults to the emergency room every year. How your arteries physically change as you age, and why that makes a higher blood pressure reading not just normal, but sometimes necessary. The 5 signs that your blood pressure medication may be doing more harm than good. And what lifestyle changes actually move the needle on cardiovascular risk without the dangerous side effects of overmedication. Before we go further, if you're someone who watches health content and actually wants to understand your body, rather than just being handed a diagnosis and a pill, please hit subscribe right now. It's free. It helps this channel reach more people who are being underserved by a medical system that rarely has enough time to explain any of this. Let's start with the biology, because everything else builds on this. Why aging changes everything about blood pressure. Your cardiovascular system at 70 is not the same machine it was at 35. Not even close. Here's what happens inside your arteries as you age. The walls of your blood vessels are lined with a layer of elastic fibers made of a protein called elastin. When you're young, those fibers are springy and flexible. Every time your heart beats and sends a surge of blood through your arteries, those walls stretch to absorb the pressure, then recoil. It's like squeezing a soft rubber hose. The walls give, the pressure spreads evenly, and your organs receive a smooth, steady flow of blood. But over decades, those elastic fibers stiffen. They calcify. They harden. Your arteries stop behaving like a soft rubber hose and start behaving more like a rigid copper pipe. Now when your heart beats, there's nowhere for that pressure to go. The walls can't stretch, so the pressure inside spikes higher. Then when your heart rests between beats, the pressure drops lower. This is what creates a wider pulse pressure, that gap between your top number, the systolic, and your bottom number, the diastolic. This is why it's completely normal and expected for systolic blood pressure to rise with age. It's not a disease. It's physiology. Your body is actually compensating for stiffer arteries by generating more force to keep blood flowing to your brain, your kidneys, your heart, and your extremities. The moment you aggressively suppress that compensatory pressure in a 78-year-old, you may be cutting off perfusion to organs that desperately need it. Think of it this way. Imagine a garden that's been getting water from a hose for 75 years. Over time, the hose develops kinks and narrowings. So the gardener turns up the water pressure to make sure every flower still gets enough. Now imagine someone comes along and turns the pressure back down to what it was when the hose was new and flexible. The flowers at the end of the hose, your brain, your kidneys, your eyes, stop getting enough water. They wilt. That's what aggressive blood pressure lowering can do in older adults with already stiff, narrowed arteries. What the numbers actually mean over 65. Here's where the research gets genuinely surprising and where I want you to pay close attention. For decades, the target was simple: get blood pressure below 140/90. Then in 2017, the American College of Cardiology and the American Heart Association updated their guidelines and pushed the target down to 130/80 for most adults, including many older ones. This caused an immediate jump in the number of Americans classified as hypertensive. Tens of millions of people overnight who now technically had a diagnosis that required treatment. But here's what those guidelines glossed over. A landmark study called SPRINT, the Systolic Blood Pressure Intervention Trial, which is often cited to justify aggressive blood pressure lowering, had a critical detail buried in its methodology. The blood pressure readings in SPRINT were taken with an automated device in a quiet room with no one else present. No white coat, no conversation, no anxiety. That method produces readings that are, on average, 5 to 10 points lower than the readings you get in a standard clinical setting. So when SPRINT showed benefits at a systolic below 120, the real-world equivalent was closer to 130 or even 135. The comparison was not apples to apples, and the guidelines didn't adequately communicate that. More importantly, a series of large observational studies in adults over 65 showed something that should have stopped everyone in their tracks. In older adults, particularly those over 75, having a systolic blood pressure that is too low was associated with significantly higher rates of death, cognitive decline, and kidney damage. Not slightly higher, significantly higher. A study published in JAMA Internal Medicine followed nearly 5,000 older adults and found that those with systolic blood pressure below 120 had the highest mortality rates of any group. The sweet spot for survival in adults over 75 was a systolic pressure between 130 and 145. That's right, a reading that would get you medicated immediately in most doctors' offices was actually the range associated with the best outcomes in this population. Another major analysis, published in The Lancet, pooled data from over 600,000 patients across multiple countries and found that in adults over 70, every 10-point reduction in systolic blood pressure below 130 was associated with increased risk of serious adverse events, including falls, fractures, acute kidney injury, and hospitalization. Let me say that plainly. For many older adults, lowering blood pressure aggressively doesn't just fail to help, it actively causes harm. The overtreatment crisis nobody is talking about. There is a silent epidemic happening right now inside nursing homes, assisted living facilities, and the bedrooms of older adults across the country. It's called overtreatment, and it is one of the most underreported crises in modern medicine. Here's what overtreatment looks like in real life. A 76-year-old woman comes in with a blood pressure reading of 148/82.
Her doctor sees the number, compares it to the guideline target of 130/80, and adds a second blood pressure medication to her already crowded list. 2 weeks later, she stands up from her chair, feels dizzy, and falls. She fractures her hip. She goes to the hospital. She develops a post-surgical infection. 18 months later, she's in a wheelchair, her independence gone, her cognitive function declining. Did the fall cause all of that? Not entirely. But did aggressive blood pressure medication contribute to the fall by dropping her pressure too low when she stood up? A condition called orthostatic hypotension? Absolutely yes. And this scenario plays out thousands of times every year. The American Geriatric Society has specifically warned that blood pressure targets below 140 systolic should be used with extreme caution in adults over 75, particularly those who are frail, have a history of falls, have multiple medications, or have evidence of cognitive impairment. Their position is based on exactly this kind of evidence. A study in the Journal of the American Geriatric Society found that nearly 40% of older adults on multiple blood pressure medications experienced clinically significant drops in blood pressure upon standing. That dizziness you feel when you get up too fast? That's not just an inconvenience. That's your brain briefly not getting enough blood. Every time that happens, there's a small injury. Over months and years, those injuries accumulate. The 5 warning signs your blood pressure medication may be doing more harm than good.
I want you to write these down or screenshot this section, because this is the part that most people never hear from their doctor. Warning sign number 1. Dizziness or lightheadedness when you stand up. This is orthostatic hypotension. It means your blood pressure is dropping too fast when you change positions because your medicated resting pressure is already too low. If this is happening to you, your dose may need to be adjusted. Warning sign number 2. Fatigue that wasn't there before. Many older adults on blood pressure medications report feeling exhausted, unmotivated, and mentally foggy. Several common blood pressure drugs, particularly beta blockers, directly reduce your heart rate and cardiac output. In a younger, healthy heart, that's manageable. In an older, already slower heart, it can leave you running on empty. Warning sign number 3. Worsening memory or concentration. This one is rarely discussed but critically important. Your brain requires a constant, adequate supply of blood. If your blood pressure is pushed below the level your stiffened arteries can effectively deliver blood, your brain literally gets less oxygen. Studies have linked overly aggressive blood pressure treatment in older adults to faster cognitive decline, not slower. Your doctor should be considering this trade-off. Warning sign number 4. Cold hands and feet. This signals reduced peripheral circulation. Again, if your pressure has been pushed down too far, your body starts rationing blood flow away from the extremities. That persistent coldness is your body telling you that the pump isn't getting blood to the far corners. Warning sign number 5. You have no symptoms at all from your blood pressure. This matters because high blood pressure in older adults is often described as dangerous because it has no symptoms. But here's the flip side. If you had no symptoms before medication, no headaches, no shortness of breath, no chest pain, and now you have fatigue, dizziness, and brain fog, you've traded a theoretical future risk for a very real present harm. That calculation deserves a serious conversation with your doctor. So what is the right blood pressure target for older adults? Let me give you a framework, not a single number, because this is genuinely not one size fits all. For adults between 65 and 74 who are otherwise healthy, active, and not frail, a systolic target of 130 to 140 is supported by the current evidence. This is more aggressive than what many older guidelines suggested, but it's achievable without the overtreatment risks that come with pushing below 130. For adults 75 and older, or adults of any age who are frail, have a history of falls, have multiple chronic conditions, or are on many medications, a systolic target of 140 to 150 is increasingly supported by geriatric medicine specialists. Several leading geriatric cardiology researchers now argue that 150 over 90 in a frail 80-year-old is not an emergency. It may, in fact, be optimal. For adults 80 and older, the HIVET trial, one of the few randomized controlled trials specifically in this age group, found that treating adults over 80 to a target of 150 systolic reduced stroke risk. But the benefits were most pronounced in healthier, more robust individuals. In frailer patients, the benefit disappeared or reversed. Here is the single most important concept I can give you: individualized treatment. Your blood pressure target should be set based on your age, your frailty level, your fall risk, your kidney function, your cognitive status, your other medications, and your own goals for quality of life. A blanket guideline number handed down from a committee that studied mostly middle-aged adults is not automatically appropriate for a 78-year-old with osteoporosis, 3 medications, and mild memory issues. The best doctors know this. They have individualized conversations. They track how you feel, not just what the cuff says. If your doctor has never asked you how you feel on your blood pressure medication, that is a conversation worth starting. What actually works? Lifestyle changes with real evidence. Now here's the part I genuinely love talking about, because this is where you have real power. There are lifestyle interventions for blood pressure that are backed by the same quality of evidence as medication, with none of the dangerous side effects of overtreatment. Let me walk you through the most powerful ones, specifically for older adults. Number 1, dietary sodium reduction, done intelligently. A meta-analysis published in the British Medical Journal found that reducing sodium intake by 1,000 milligrams per day, roughly half a teaspoon of salt, reduced systolic blood pressure by an average of 5 to 6 points in older adults. That's equivalent to a low-dose medication. But the key word is intelligently. In older adults who are already prone to low sodium levels called hyponatremia, going too far can cause confusion, muscle cramps, and even falls. The goal is moderation, not elimination. Number 2, the DASH diet. The dietary approaches to stop hypertension diet has been studied extensively and shown to reduce systolic blood pressure by 8 to 14 points, which is greater than most single blood pressure medications. It's rich in potassium, magnesium, and calcium from whole foods, fruits, vegetables, whole grains, lean protein, and low-fat dairy. The mechanisms are clear. Potassium relaxes blood vessel walls. Magnesium reduces arterial spasm. And the overall anti-inflammatory effect of a whole food diet reduces the underlying vascular damage that drives hypertension. Number 3, exercise, specifically the right kind. Here's what most people get wrong. High-intensity cardio is not necessarily the best exercise for blood pressure in older adults. A systematic review published in the British Journal of Sports Medicine found that isometric exercise, specifically wall sits and hand grip exercises, produced the largest reductions in both systolic and diastolic blood pressure, outperforming traditional aerobic exercise. Wall sits are simple, low injury risk, and can be done in under 5 minutes. 4 sets of 2-minute wall sits 3 times a week produced an average 8-point reduction in systolic pressure in multiple studies. For an older adult who can't run, this is a game changer. Number 4, reducing alcohol. Even moderate alcohol consumption raises blood pressure in older adults more than in younger people because the aging liver processes alcohol more slowly, keeping blood alcohol levels elevated longer. Limiting alcohol to 1 drink per day or fewer has been shown to reduce systolic pressure by 3 to 4 points on average. Number 5, sleep quality. This one is massively underrated. Blood pressure naturally drops during sleep in a pattern called nocturnal dipping. If you're sleeping poorly, waking frequently, or have undiagnosed sleep apnea, your blood pressure may not be dipping as it should, which drives daytime readings up. A study in the American Journal of Hypertension found that treating obstructive sleep apnea in older adults reduced 24-hour blood pressure by an average of 6 to 10 systolic points. Before adding a blood pressure medication, a sleep study is worth considering. Number 6, stress reduction, specifically mindfulness-based practice. A review published in the Journal of Human Hypertension analyzed 13 studies and found that regular mindfulness meditation reduced systolic blood pressure by an average of 4.7 points. That's not nothing. Combined with the other interventions above, you're looking at a potential 20 to 30 point reduction from lifestyle alone without a single additional pill. The conversation you need to have with your doctor. I want to leave you with something practical, because information alone doesn't help if you don't know what to do with it. If you are over 65 and currently on blood pressure medication, or if your doctor is considering starting you on blood pressure medication, here are the specific questions you should ask at your next appointment. Ask, what is my individualized blood pressure target, and how was that target chosen for me specifically, given my age and health history? Ask, is my current blood pressure actually causing symptoms, or are we treating a number on a chart? Ask, what is my fall risk, and has that been factored into my blood pressure target? Ask, can we trial lifestyle changes first, or, if I'm already on medication, can we try a dose reduction and monitor how I feel? Ask, can you check my blood pressure both lying down and standing to screen for orthostatic hypotension? These are not confrontational questions. They are the exact questions that a well-trained geriatric cardiologist would consider standard of care. You have every right to ask them, and a good physician will welcome them. 1. Aging stiffens your arteries, which naturally raises blood pressure. This is physiology, not always disease. A higher reading in an older adult does not automatically require the same response as in a younger person. 2. Major research, including studies in JAMA, The Lancet, and the New England Journal of Medicine, shows that in adults over 75, a systolic blood pressure between 130 and 145 is often associated with better survival outcomes than readings below 120. 3. Overtreatment is a real and dangerous problem. Pushing blood pressure too low in older adults causes falls, fractures, kidney damage, cognitive decline, and hospitalization. 4. The 5 warning signs that medication may be doing more harm than good are orthostatic dizziness, unexplained fatigue, worsening memory, cold extremities, and trading no symptoms for new ones. 5. For adults 65 to 74, a systolic target of 130 to 140 is generally appropriate. For adults 75 and older, especially those who are frail, a target of 140 to 150 is increasingly supported by the evidence. 6. Lifestyle interventions, including sodium reduction, the DASH diet, isometric exercise, alcohol reduction, sleep optimization, and mindfulness, can collectively reduce systolic pressure by 20 to 30 points without the risks of over-medication. 7. You deserve an individualized conversation with your doctor, not a generic guideline number applied without context. Ask the questions. Push for personalized care. Your blood pressure is not just a number. It's a signal from a living, aging, adapting cardiovascular system that has kept you alive for decades. Treat it with the nuance and respect it deserves. And make sure the people caring for you do the same. If this video gave you something your doctor's appointment didn't, share it with a parent, a spouse, a sibling, or a friend who is navigating blood pressure decisions and feeling overwhelmed. They deserve to know this too. And subscribe so you don't miss what's coming next, because we're going deeper into the specific medications that carry the highest fall risk in older adults, and what to ask your doctor about safer alternatives. The links are right here. I'll see you in the next one.